Welcome back to the deep dive. This is where we take the densest, most important information, analyze the connections across multiple expert materials you've shared with us, and deliver the essential, actionable insights.
Today we are taking a necessary, deep, and frankly overdue plunge into a topic that affects, what, 1 in 5 people globally?
At least, we're talking about chronic pain, and we're going to be dissecting the sources that explain a really important shift in how the medical community views, classifies, and most importantly, treats persistent pain.
That's right. Our mission today is focused on understanding a proposal made by the International Association for the Study of Pain, or the IASP, back in 2016.
And they introduced a brand new term, didn't they? A third pillar in the world of pain descriptors.
They did, nociplastic pain. And look, this is so much more than just medical jargon. It fundamentally changes the conversation around chronic suffering.
How so?
Well, it provides physiological validation for pain experiences that were for a long time ignored or dismissed or even labeled as purely psychological.
So we really need to explore the exact mechanisms that drive this pain. Mechanisms that, and this is the key, originate not in a damaged knee or a compressed nerve,
But in a hypersensitive nervous system, the problem is in the processing, not necessarily the peripheral tissue.
Okay, so let's unpack this and set the stage. Before this new classification, the model for understanding pain was, well, it's surprisingly simple, right? A classic binary system.
The dichotomy, yeah. It felt like clinically you had 2 boxes, and if a patient's pain didn't fit neatly into either one.
They were often sent home confused or worse, feeling like they weren't believed.
Exactly. The system was robust for, say, an acute injury, but it failed miserably when it came to chronic complexity. So box number 1 was what we call nociceptive pain.
This is the one we all kind of intuitively understand.
It's the most instinctive understanding of pain, for sure. It's the pain resulting from actual or even threatened damage to non-neural tissue. Think of your classic physical traumas.
A broken bone, a surgical site.
Right, the inflammation from arthritis, a
Yeah.
sprained ligament. This pain mechanism relies on activating nociceptors. Those are the sensory receptors that basically scream damage to the brain.
And I guess the beauty of nociceptive pain, if you can call it that, is that the treatment path is pretty clear.
Precisely. You address the peripheral injury. It responds to peripherally directed therapies.
So anti-inflammatory drugs like NSAIDs, physical therapy to heal the tissue.
Or surgery to fix the mechanical problem.
Yeah.
You treat the site of the injury, and generally the pain gets better as the tissue heals. It's a very logical cause and effect relationship.
Okay, so that was box number 1. Then we had box number 2, neuropathic pain.
This is the pain category that emerged as we got a better handle on the nervous system itself. Here, the problem isn't the tissue, it's the electrical wiring.
The nerves themselves are damaged.
The nerves are the source of the problem.
Mhm.
Neuropathic pain is defined as pain caused by a lesion or a disease of the somatosensory nervous system. That could be your peripheral nerves or the central nervous system.
So classic examples would be something like sciatic pain from a compressed nerve.
Sciatica is a perfect example. Or the persistent burning pain you might get from nerve damage due to diabetes, chemotherapy, or shingles. That post-herpetic neuralgia, that's all neuropathic.
So we have pain from damaged tissue nociceptive and pain from damaged wires neuropathic. But as soon as clinicians started dealing with these chronic, widespread, complex conditions, this 2-box system revealed a massive, frustrating gap.
Yes, what the experts started calling the nebulous zone.
And this nebulous zone was, I imagine, a clinical disaster for both the patient and the doctor.
It was a total disaster. This area contains so many chronic pain conditions: fibromyalgia, many forms of tension headaches, irritable bowel syndrome, that nonspecific chronic low back pain.
All presenting with agonizing, debilitating, and measurable symptoms, or what they call phenotypes.
Exactly. The symptoms were very real. But the crucial absence was objective evidence. They couldn't find clear, identifiable, ongoing evidence of either inflammation or specific nerve damage.
I see the problem immediately. You have a patient with years of widespread pain, profound fatigue, sleep disturbance. The clinician runs blood tests, orders an MRI.
And everything comes back normal or inconclusive.
So if the underlying mechanism isn't clear, where does that leave the patient?
It left them marginalized and, frankly, stigmatized. Without a clear mechanistic explanation, these patients were often diagnosed with what were really wastebasket terms.
What do you mean by that?
Labels like dysfunctional pain or, even worse, medically unexplained somatic syndromes.
That sounds incredibly dismissive.
It is, and it fosters a massive amount of patient mistrust, frustration, and a sense of being medically dated, which only adds to the pain experience itself. The pain was real, but the medical language just couldn't validate it.
So the framework itself was failing millions of people. This is the catalyst for change then. The IASP Terminology Task Force officially stepped in.
They stepped in and proposed the third pillar in 2016, nociplastic pain, NP. And this finally validates an experience that clinicians already knew existed, but they just didn't have a good name for it.
So this new category was necessary just to provide a positive physiological descriptor for these pain states.
Yes, pain states that result from amplified signaling.
Okay, so what then is the core mechanism that truly defines this third pillar? How is it fundamentally different from the first two?
The difference is that the problem isn't the input, like tissue damage, or the wiring, like nerve damage. The problem is the central processor itself.
The brain and spinal cord.
Nociplastic pain is mechanistically defined as pain arising from the altered function of pain-related sensory pathways in the periphery and, most significantly, the central nervous system, the CNS. This leads to an overall increased sensitivity.
It's an issue of gain then. Like the volume knob for pain is stuck on maximum.
That's the perfect analogy, and that immediately reframes the condition. It's not about finding the injury anymore. It's about treating the hypersensitized system.
And that's really the core message we need to convey today, isn't it?
It is. By understanding this new NP framework, we can validate the pain complaints that were previously overlooked. We can assure patients, and you, the listener, that this pain is absolutely real. It's rooted in measurable neurophysiological changes in the brain and spinal cord.
And recognizing those NP mechanisms is the critical first step toward effective treatment, right? Because therapy is directed only at the periphery.
Like the ones for nociceptive pain.
They're almost guaranteed to fail here.
Absolutely guaranteed to fail.
Okay, so let's move into a more precise definition. What is the official semantic language used to capture this idea of nociplastic pain?
Well, the official definition says NP describes chronic pain states that are not predominantly explained by obvious tissue damage, so nociception or pathology, of the somatosensory system neuropathy.
Okay, so it's defined by what it isn't.
To start with, yes. But then it's defined by what it is. The diagnosis is made when clinical findings and psychophysical data.
What's that? Psychophysical data.
It just means tests that measure sensory responses, like how you react to pressure or temperature. So when those findings strongly suggest an altered function of the pain pathways leading to this heightened sensitivity, the system is dysfunctional, not structurally damaged.
This definition immediately leads us to the unique signs of what's called the nociplastic phenotype. It's not just persistent pain, it's pain that comes with a specific set of red flags that point toward the CNS being involved.
Yes. The primary feature that really distinguishes NP clinically is multifocal pain.
Meaning pain in multiple places.
In multiple places, yeah. The pain is generalized, it's widespread, or it's intense. Often it's both. And it's way beyond what you would expect if you only considered the amount of identifiable structural damage.
Can you give an example?
Sure. If a patient has, say, minor osteoarthritis in their right knee, but they're reporting severe pain in their structurally sound left knee and their hip and their shoulder, that widespread distribution is a huge clue that the centralized amplifier is on.
And what really clinches the diagnosis are those associated symptoms, the ones that are derived from the CNS itself. These are the telltale signs that the whole system is compromised.
Precisely. These are the comorbid symptoms that are so characteristic of conditions like fibromyalgia. We're looking at a whole suite of systemic problems.
Like fatigue.
Profound fatigue, the kind that isn't relieved by rest, and chronic, debilitating sleep disturbance. Often patients will say they feel like they haven't slept at all, even after 8 hours.
And then there are the cognitive issues.
Significant memory and mood problems. This often presents as anxiety, depression, or that classic brain fog, cognitive difficulty.
And the sensory systems outside of pain are also affected, aren't they? That's a really interesting part of this.
Yes, that's key. Hypersensitivity to non-nociceptive sensory stimuli.
Meaning things that shouldn't hurt do, or at least feel overwhelming.
Exactly. Think about how uncomfortable a patient becomes when exposed to normal light. We call that photosensitivity, or normal sound levels, known as hyperacusis. For a nociplastic patient, the ambient noise in a busy supermarket isn't just annoying. It can be physically painful.
So their whole sensory filtering system is completely overloaded.
It is. And this proves the system is fired up universally, not just for pain signals.
It sounds like NP functions as a mechanism descriptor then. It's an overarching term, not a disease itself.
That's the critical distinction to make. NP is not a diagnosis like diabetes or fractured femur. It is a physiological descriptor that we can apply to a whole range of diverse clinical conditions.
Like fibromyalgia, interstitial cystitis, tension-type headache, IBS.
All of those conditions that share this common neurophysiological pathway of sensitization. And this is so important because it shifts the focus from hunting for a single structural cause to treating the shared underlying mechanism, which is much more effective.
And it gets rid of those stigmatizing labels we talked about earlier.
It does. I can see how powerful that is for the patient. You're telling them, look, we may not know the initial cause, but we know exactly how your brain is processing this pain, and we can target that mechanism.
That validation alone must be therapeutic.
It is, absolutely. And by focusing on the mechanism, we can now confidently take findings from the most studied NP condition, which is fibromyalgia, and apply them to other seemingly different chronic pain states.
But let's introduce a point of clinical friction here. We're defining these three neat categories: nociceptive, neuropathic, and nociplastic. But the sources stress that NP often occurs as a comorbidity. It can be part of a mixed pain state. Doesn't trying to categorize the pain risk oversimplifying things.
That's a great question, and it speaks directly to the reality of clinical practice. The truth is, chronic pain rarely fits neatly into just one box. Many, maybe even most, chronic pain states represent a mixed picture.
So like chronic low back pain.
Chronic low back pain is the perfect example. You might have an initial tissue strain, which is nociceptive, maybe some mild nerve root irritation, a small neuropathic component, and then, critically, the pain persists long after the tissue should have healed.
Because the central nervous system has become sensitized. That's the nociplastic part.
That's the nociplastic part. It's taken over.
And the statistics really underscore how common this overlap is.
They do. Studies suggest that up to a third of all chronic pain conditions involve some combination of the three mechanisms. The essential clinical insight here is that even when a patient has a documented, clear, nociceptive condition, say, inflammatory arthritis,
You have to screen for a nociplastic component.
you must, because it drastically worsens the patient's prognosis and it makes traditional treatments fail.
Why is that? Why is recognizing that nociplastic component so essential in those cases?
Because if the physician focuses only on the joint inflammation and misses the central sensitization, they'll just keep increasing the dose of anti-inflammatories or biologic drugs. Those might help the joint, but they won't touch the centralized amplified pain.
So recognizing the NP component means you have to add centrally directed treatments to the plan.
And we see comorbid NP mechanisms in roughly 20% of patients with inflammatory arthritis and up to 25% of patients with osteoarthritis. This isn't a rare thing. It's a necessary screening tool for effective management.
This framework also integrates perfectly into global diagnostic standards, doesn't it? Specifically, the World Health Organization's new ICD-11.
Yes, the ICD-11 provides a huge endorsement of this physiological approach. The NP category applies particularly to what the ICD-11 now defines as chronic primary pain conditions.
Okay, what does that mean, chronic primary pain?
These are defined as chronic pain in one or more anatomic regions that's associated with significant emotional distress or functional disability, and they can't be better explained by another chronic pain condition.
So chronic primary pain, which includes things like chronic widespread pain, complex regional pain syndrome, and chronic primary headaches, is fundamentally rooted in this dysfunction of nociceptive processing.
Exactly. This classification finally removes that old implicit suggestion that if we can't find tissue damage, the problem must be purely psychological. Instead, the ICD-11 is saying the problem is the causal dysfunction of the pain processing system itself.
It moves the diagnosis firmly into the realm of measurable neurophysiology.
A huge step forward.
Okay, we've established the clinical definition. Now let's move inside the body, into the engine room, to really get our heads around the mechanism. The technical, mechanical common denominator for all nociplastic pain is central sensitization.
This is where we fully shift our focus from the periphery to the CNS. Central sensitization is, well, it's defined as the amplified processing of pain stimuli, or just as often, the decreased ability to inhibit those stimuli across various levels of the nervous system.
The spinal cord and the brain.
The spinal cord and the brain. The nervous system is no longer just reporting pain. It is actively creating and amplifying it.
When did we first start understanding this concept? It feels very modern.
The term central sensitization was actually proposed way back in 1983 by a researcher named Clifford Wolff. At the time, he was primarily focused on spinal mechanisms, so how the neurons in the spinal cord become hyperresponsive and augment that peripheral nociceptive input.
But our understanding has grown since then.
Oh, massively. What we understand now is that this process can really start in two ways.
The two pathways to sensitization.
Right. It could be a bottom-up response where a peripheral injury like a sprain triggers the initial sensitization, but then the CNS keeps the process going long after the initial trigger is gone.
So the ankle sprain heals, but the foot remains chronically painful.
Exactly. Or it could be a top-down CNS-driven response. This is often linked to things like psychological stressors or systemic issues, where the brain itself actually initiates the hyper-response without a clear peripheral injury to start it off.
But regardless of the initial trigger, the result is the same. The final common pathway is an amplified perception of pain. And the really cool thing is that we can actually measure this amplification now.
We can. We use techniques like quantitative sensory testing, or QST.
hmm
And QST provides the objective evidence we so desperately needed in this field.
So what does it measure? What are the classic manifestations of a hypersensitive system?
There are three main ones.
Okay, let's break those down, starting with the most basic, hyperalgesia.
Hyperalgesia is pretty straightforward. It's an increased pain response to stimuli that are normally painful.
So if you pinch a healthy person, they might rate the pain as a 3 out of 10.
Right. But if you pinch a nociplastic patient with the exact same force, they might rate it as an 8 out of 10. The body's response system is just overreacting to an expected painful input.
And the second manifestation is much more dramatic, allodynia.
Allodynia is really the defining characteristic of severe sensitization, and it's just devastating for patients. It's defined as a pain response to stimuli that are normally non-painful.
So to make this practical for you, the listener, this means that something as simple as the weight of a light bedsheet on your skin.
Or the gentle movement of air from a fan, or even just a slight temperature change that should feel innocuous, registers in the brain as debilitating, searing pain.
And this often extends far beyond the original injury site, right? Which strongly suggests the problem is in the brain.
It does. It points to the processing dysfunction being supraspinal at the level of the brain, not just a localized spinal cord issue.
That really brings home the reality of the patient's suffering. Their everyday life becomes a minefield of painful triggers. And the third measurable finding is temporal summation, or wind-up. That's a fascinating name.
It is, and it describes the mechanism perfectly. Temporal summation is the phenomenon where a patient experiences increasing pain perception after repeated noxious stimuli.
Okay, what does that look like?
Imagine applying a very low-level heat stimulus 10 times in the same spot. In a healthy person, the 10th stimulus feels the same as the first. But in a nociplastic patient, the signal pathways in the spinal neurons are enhanced after repeated firing.
So the first stimulus might register as a 2, the second as a 4, the third as a 6, and so on. The system is literally winding up the pain response with each input.
Exactly. The system is amplifying the signal each time, which contributes directly to the chronic nature of the pain.
Yeah.
And if amplification is one side of the coin, the other side is, well, it's the lack of brakes.
Tell us about the failure of the brain's internal analgesic system.
We call this diminished descending inhibition. The brainstem contains these critical nuclei that project down to the spinal cord, and their job is to modulate or turn down the pain signals traveling up from the body.
It's the brain's natural internal volume control system.
It is. And in nociplastic states, this descending analgesic system is weak or abnormal. The brain's ability to turn down the signal is deficient, which contributes significantly to the persistent allodynia and hyperalgesia. And we can actually measure this failure.
It's amazing that we can finally see the neurophysiological mechanism underlying years of subjective suffering. We're moving beyond the spinal cord now and up into the brain.
We are no longer relying only on patient report. Modern imaging is letting us watch this fired-up nervous system in real time.
And that's the true power of functional MRI and PET scans.
It is. When researchers compare fMRI scans of patients with conditions like fibromyalgia, IBS, and chronic low back pain to healthy controls, especially when they give them a standardized painful stimulus, they see profoundly different neural activation patterns.
What are the distinct patterns of brain activity that characterize this nociplastic state?
Well, the first pattern is increased activity and connectivity. We see a massive surge in activation in brain regions involved in augmenting pain and emotion.
Which regions are we talking about?
The sources point specifically to the insular cortex, which acts as the body's major internal sensory hub. It integrates signals from the body, including pain, with emotional and cognitive context. When this area is hyperactive, every single signal becomes more urgent.
And we also see increased connectivity in areas like the default mode network.
Right, which is normally active during introspective thought, kind of when your mind is wandering. When the DMN is hyperconnected to pain networks, the brain essentially starts ruminating and focusing on the pain constantly.
So the areas responsible for signaling pain and emotion are overworking and talking to each other too much. What about the flip side of that?
The second pattern is decreased activity. And this is found precisely in those brainstem regions responsible for the descending analgesic, the pain-inhibiting mechanisms we just discussed,
So the system that should be shutting the pain down is quiet.
while the system that is amplifying it is screaming.
The sources also go into the neurochemistry, which provides an even deeper explanation. It's not just about which areas are active, it's about the specific chemical messengers.
The neurotransmitters, yeah, absolutely. We can move to something called proton spectroscopy, which is basically chemical imaging. And this shows us a literal imbalance in the brain's gas and brake pedals.
Okay, explain that analogy.
On the accelerator side, we find increased glutamatergic activity. Glutamate is the primary excitatory neurotransmitter in the CNS. It's the gas pedal. On the other side, we see decreased GABAergic activity. GABA is the primary inhibitory neurotransmitter. It's the brake pedal.
So this imbalance, particularly in key pain regions like the insula, means the pain signals are constantly being amplified because the inhibitory control is failing.
Too much gas, not enough brake. And there's even evidence pointing toward inflammation within the CNS itself.
Neuroinflammation.
Yes, through PKI scanning, we see strong support for neuroinflammation and the involvement of glial cells. These are the brain support cells, and when they get activated, it indicates an inflammatory state in conditions like fibromyalgia.
So it's not inflammation of the knee, it's inflammation of the nervous system.
That's the distinction. Furthermore, and this is a huge clinical insight, PET studies have shown decreased central mu-opioid receptor availability.
That is a crucial piece of the puzzle. Why does the lack of available mu-opioid receptors matter so much in the clinical context of treating nociplastic pain?
Because the mu-opioid receptor is the target for all prescription opioids. If the brain already has a decreased availability of these receptors, or if its own internal opioid system is struggling, then introducing external opioids will be far less effective.
And it can actually worsen the problem, right?
It can. It can further desensitize the system or even induce more hyperalgesia. It provides a really solid neurochemical justification for the strong guideline against using traditional opioid painkillers for these conditions.
That connection between neurochemistry and treatment is so important. Finally, there was this older, very worrying idea that chronic pain might cause structural brain atrophy. What does the current research say?
The current understanding has shifted significantly away from that, thankfully. While we do observe changes in the size and shape of gray and white matter regions in chronic pain patients, experts now believe these changes indicate neuroplasticity, not irreversible damage.
So the brain isn't shrinking, it's actively changing its wiring.
It's changing its connections, its structure. It's learning to be exquisitely sensitive in response to years of chronic pain signaling. And this is crucial because neuroplasticity, while it's causing the problem, also holds the key to the solution.
The system can potentially be rewired back toward a state of normal sensitivity.
Through targeted treatment, yes.
Now that we understand the mechanism, let's contextualize the scope of nociplastic pain. Globally, chronic pain affects 1 in 5 people. Within that enormous population, how many are we talking about here?
Well, nociplastic pain mechanisms are estimated to affect a really substantial portion, somewhere between 5% and 15% of the general population.
That represents millions and millions of individuals whose pain, until recently, lacked this precise, validating physiological descriptor. And we noted a clear demographic bias across many of these syndromes.
That's right. The prevalence tends to be higher for female individuals. You often see a 2-to-1 female-to-male ratio across many of these nociplastic syndromes.
And when we look at why this happens, the sources overwhelmingly point to the biopsychosocial model.
We rarely find a single isolated causal factor. NP seem to emerge from this dynamic interplay of biological, psychological, and social factors that either predispose an individual or trigger the sensitization process.
So what are some of the common predisposing factors that prime the nervous system to become hyperresponsive?
The factors are diverse. They include a family history of chronic pain, which suggests a potential genetic or epigenetic vulnerability. Also prior, sometimes even minor pain experiences that might have initiated some early sensitization loops.
And the sources really highlight psychosocial stressors.
They do, most significantly. Particularly a history of trauma or abuse. That could be psychological, emotional, sexual, or physical. These stressors are thought to profoundly disrupt the body's stress response and pain inhibition systems, making the nervous system highly reactive later in life.
So it's just a lifelong pattern of vulnerability, and then specific triggers can push that prime system over the edge.
They can. Triggers can range from sustained psychosocial stress, like a prolonged conflict at work or bereavement, to acute biological events. For example, specific gastrointestinal infections have been identified as a trigger in a lot of patients who go on to develop irritable bowel syndrome.
Okay, let's focus on the classic archetypal condition here. Chronic widespread pain, best exemplified by fibromyalgia.
Fibromyalgia really is the gold standard for nociplastic syndrome. It's defined by that widespread multifocal pain, and it's accompanied by all those chronic CNS-derived symptoms we discussed.
The relentless sleep disturbance, the debilitating fatigue, the cognitive difficulties or brain fog.
And frequently comorbid mood disorders. Its prevalence is around 2 to 4% of the general population.
The section on fibromyalgia contains one of the most sobering statistics in the entire source material, the profound, unacceptable delay in diagnosis. We need to spend a minute on this because it shows the real-world cost of not having this framework sooner.
It is truly staggering. I mean, imagine being in agonizing, widespread pain for years, visiting doctor after doctor, only to be told your tests are all normal. A large survey found that patients experience symptoms for a mean duration of 89 months.
That's over 7 years.
Over 7 years.
Yeah.
But it took them an average of 35 months, almost 3 years, and interactions with about 4.5 physicians just to receive the actual fibromyalgia diagnosis.
Over 2.5 years of actively searching for a diagnosis, all while dealing with 7 years of symptoms. That delay must breed so much distrust and desperation.
And that desperation leads to excessive healthcare use, the very historical marker we now look for. The sources suggest part of the difficulty historically was the reliance on older, very specific diagnostic criteria, particularly the physical requirement of a certain number of tender points.
Right, I remember that, where they'd press on specific spots.
Exactly. Newer criteria have removed those numerical thresholds, which is a major step forward, and it's expected to address the previous underdiagnosis of FM, especially in male individuals who might present a bit atypically.
And these nociplastic mechanisms aren't just confined to diffuse conditions like fibromyalgia. They contribute significantly to localized conditions that become chronic, like nonspecific chronic low back pain.
CLBP is the single leading cause of disability worldwide, and the data is just striking. A vast majority, up to 85%, of chronic back pain cases lack a clear pathoanatomical explanation.
So there's no clear structural cause.
Right. And the key insight that emerged from research is that the structural changes we often see on imaging like disc bulges or mild degeneration on an MRI are highly common in completely asymptomatic people. The sources emphasize there's a very poor correlation between these structural findings and the actual intensity of the pain.
So the structural damage is often just an incidental finding of aging, not the cause of the persistent pain.
Exactly. When low back pain persists for months or years without a clear structural issue that would warrant surgery, it's highly probable that the persistence is due to a prominent nociplastic component. The body has healed, but the central nervous system hasn't turned off the alarm.
And this visceral hypersensitivity is also the hallmark of conditions like irritable bowel syndrome.
Yes, IBS, which affects 5 to 10% of the population, involves a classic NP mechanism known as visceral hypersensitivity. The gut itself becomes overly sensitive to normal internal stimuli like gas or movement, alongside clear evidence of impaired CNS processing of those signals. The system is just hypervigilant for internal stimuli.
A similar pattern seems to hold true for bladder pain syndrome as well.
It does. In bladder pain syndrome, the presentation of the pain is critical. If the patient's symptoms are strictly localized to the bladder area, their sensory testing and imaging results might look identical to healthy controls.
But if the pain becomes widespread,
Right. If it starts to incorporate those classic CNS symptoms, the fatigue, the sleep issues, the widespread tenderness, then the findings start to mirror fibromyalgia, and the patient's prognosis immediately worsens. That necessitates a centralized treatment approach.
we've talked a lot about what the pain is not. It's not always purely nociceptive or neuropathic. Qualitatively, how do patients typically describe nociplastic pain?
Well, clinicians report that when patients describe this pain, they often use classic nociceptive adjectives: dull, deep, and persistently aching, probably because the initial cause was musculoskeletal.
But it often includes a neuropathic quality too, right? Like burning or shooting pain.
Yes, even though there's no confirmed physical nerve damage. But what is most distinctive is the volatility. The pain characteristically fluctuates wildly in location and intensity. It moves around the body.
And it's easily aggravated by factors that have nothing to do with physical damage.
Right. Emotional distress, stress, or environmental stimuli like changes in the weather or barometric pressure. These are non-physical factors that place systemic stress on an already hypersensitive nervous system, and that immediately ratchets up the volume on the central amplifier.
This brings us to the immense clinical challenge of actually diagnosing nociplastic pain. Because it lacks a biomarker, there's no definitive blood test or X-ray finding. The features are almost entirely subjective.
They are. It all relies on the patient's report, with the exception of finding widespread tenderness on examination.
In modern medicine, which leans so heavily on objective lab results, that must be incredibly frustrating. But isn't relying on subjective history precisely why these patients were dismissed in the past? How do clinicians avoid falling into that trap now?
That is the critical question.
Yeah.
The answer lies in the rigor of the classification itself. We're not looking for vague symptoms. We are looking for a highly specific, predictable pattern of symptoms, that nociplastic phenotype.
So the sources emphasize that a comprehensive history is the indisputable foundation.
It is. The clinician has to become an expert pattern recognizer, listening for clear clues that the entire nervous system is sensitized or fired up, rather than just looking for a simple injury.
What are the historical markers that should immediately raise the suspicion that the pain mechanism is centralized?
Well, the clinical guidelines provide a sort of map of sensitization. We're looking for evidence of a sensitized system from an early age, a childhood or adolescent history of frequent pain, like recurrent headaches or growing pains, which suggests a lifelong vulnerability.
And then looking for those prominent systemic symptoms we've discussed, the fatigue, the cognitive issues, the mood problems.
Right. Those are all signals that the CNS is overloaded. And we must ask about generalized sensory amplification. Are they intolerant to bright lights or loud noises?
And the patient's frustrating journey through the healthcare system itself becomes a diagnostic marker.
Absolutely. One of the strongest clues is a history of high use of healthcare services. These are often patients who are desperately searching for validation for a pain that multiple doctors can't explain. They've seen specialists, they've had countless tests, received various ineffective treatments.
And a poor response to conventional painkillers.
Yes, a poor or non-existent response to conventional analgesics, particularly prescription opioids and NSAIDs, is a flashing warning sign that the pain mechanism is central, not peripheral. You're trying to treat an amplification issue with peripheral blockers. It won't work.
Since a definitive test isn't available in standard practice, are there tools that help quantify this otherwise subjective symptom burden?
Yes, there are. While they aren't diagnostic on their own, we have assessment tools that act as surrogate measures for central sensitization. Questionnaires like the Central Sensitization Inventory or the Fibromyalgia Survey criteria are invaluable.
They don't give a diagnosis, but they quantify the symptom load.
Exactly. They quantify the number and severity of symptoms related to the widespread pain, the fatigue, the sleep, the mood. This provides the clinician with an objective metric to track the severity of the centralized involvement over time.
But the sources stress a crucial caveat about these questionnaires. We can't just rely on a single score.
That's vital. The diagnosis should never be based solely on hitting some numerical threshold on a questionnaire. NP symptoms fluctuate. Clinical judgment must always prevail, combining the pattern of symptoms, the history, and a physical exam.
And there's another major clinical instruction. Clinicians must proactively avoid unnecessary investigations.
Yes, this is so important. For nonspecific back pain, for instance, ordering serial spine MRIs is almost always counterproductive. The sources warn that unnecessary investigations don't just waste resources, they can actively exacerbate patient distress. By reinforcing a sick role, it leads the patient to believe their pain must be caused by some profound structural failure they can see on the scan, even if that finding is totally incidental. The clinician's job is to explain that the structural changes are often irrelevant and shift the focus to the nervous system.
So we have to remember, QST and fMRI are research tools for now. The clinical diagnosis rests firmly on the skilled interpretation of the patient's story.
It does. The true art here is listening for the pattern, validating the subjective experience, and selectively ruling out other conditions, all while actively avoiding that diagnostic rabbit hole of endless, unnecessary tests that can actually worsen the patient's distress.
Okay, so once the complex diagnosis of nociplastic pain is established, the treatment pathway is highly structured. and it has to begin with communication and validation.
The first step, according to all guidelines, is the empathetic delivery of the diagnosis. The clinician has to acknowledge that the symptoms are undeniably real and then explain the neurophysiological mechanism using clear, simple terminology.
A hypersensitized or fired up nervous system is the metaphor they often use.
It is. It works.
This foundational step of patient education is so often overlooked, but here it's mandatory. And part of that education has to be setting realistic expectations.
Realism is the linchpin of success in managing chronic pain. The goal of management must be directed towards attenuating symptoms and significantly improving function and quality of life, not promising total pain eradication.
Because overly optimistic expectations will just lead to disappointment.
And patient disengagement from what is a long, slow process of resensitizing the nervous system. The patient needs to understand that they are managing a chronic condition, like diabetes, not curing an acute injury.
Now, for the management mandate itself, which strongly dictates prioritizing non-pharmacological measures first, why are medications placed second for NP?
Because the core problem is a system malfunction, not a lack of a chemical compound. Most medications, even the approved ones, offer only modest benefits for NP, and they often come with adverse effects, which NP patients are often more susceptible to.
So the approach is highly structured, starting with education and self-management. Let's dedicate some time to those core non-pharmacological pillars. What does comprehensive patient education entail?
Well, beyond just explaining the mechanism, patient education means promoting self-management. It fosters an internal locus of control. The patient learns that they have agency over their nervous system.
And this is paired with foundational lifestyle efforts.
Yes, establishing rigorous sleep hygiene, since sleep disturbance is a core symptom. Managing diet and weight, incorporating stress reduction techniques, and critically engaging in physical activity. These habits are non-negotiable for cooling down a chronically sensitized nervous system.
I want to focus on physical activity. We assume exercise is good for all pain, but the sources paint a more nuanced picture for NP, especially concerning chronic low back pain.
We have to be careful about how we grade the evidence. The sources note that for chronic low back pain, for example, the evidence for exercise improving long-term function is actually graded as low. It might not be a silver bullet that fixes the pain.
So what's the nuance here?
The nuance is that for a sensitized system, traditional aggressive physical therapy can actually cause pain flares and exacerbate symptoms. The key to successful exercise in NP is pacing, starting extremely low and slow to avoid winding up the system. It's about movement and graded exposure, not pushing through the pain.
And what about physical modalities like massage or ultrasound?
For these centralized conditions, modalities like massage, laser therapy, or ultrasound generally have insufficient or low evidence for providing sustained improvements in pain or function. They're peripheral treatments for a central problem.
Psychological interventions are clearly highly integrated into this treatment plan. How do approaches like CBT and mindfulness address a sensitized nervous system?
Psychological therapies are critical because the brain's appraisal of pain profoundly influences the central amplifier. Cognitive behavioral therapy, CBT for instance, has shown small but reliable beneficial effects in reducing pain intensity, disability, and emotional distress.
And how does it work?
It works by helping patients identify and challenge the catastrophic thought patterns and fear avoidance behaviors that perpetuate the pain cycle. It's about changing the cognitive software that's running the pain system.
And how do other strategies like mindfulness compare?
Acceptance-based interventions like mindfulness and hypnotherapy are often recommended alongside CBT. The evidence for their long-term effectiveness is a bit less robust, or in some reviews, conflicting. But they serve an important function. They help the patient relate to the pain differently.
Moving from fighting the sensation to observing it.
Yes, which can dampen the central stress response.
Yeah.
Ultimately, these therapies need to be integrated into a comprehensive, multidisciplinary care program.
We briefly mentioned dietary interventions earlier. Is there compelling evidence there?
The evidence is growing, particularly around managing inflammation and gut sensitivity. Some reviews suggest that plant-based diets might help relieve musculoskeletal pain generally, maybe by reducing the systemic inflammatory load.
And for IBS specifically.
For irritable bowel syndrome, elimination diets like the low FODMAP diet are often used successfully to manage the inputs that provoke the hypersensitive gut, which can reduce those visceral pain signals.
Let's transition now to pharmacotherapy. Since the goal is modulating the CNS, what is the fundamental pharmacological approach for nociplastic pain?
The focus is strictly on centrally acting drugs, and the major mandate is opioid avoidance. We cannot stress this enough. Traditional analgesics like NSAIDs and paracetamol are poorly effective for NP, and critically, opioids are strongly discouraged.
Beyond the well-known risks of addiction, let's reiterate the specific neurobiological reasons for avoiding opioids in this population, linking back to what we discussed earlier.
The neurobiology is explicit. Opioids are ineffective in nociplastic pain because of that decreased availability of central mu-opioid receptors, the very target they need to bind to.
And more dangerously, chronic opioid use can actually worsen hyperalgesia.
A phenomenon called opioid-induced hyperalgesia. Yes. The patient becomes more sensitive to pain over time. And opioids seriously interfere with sleep architecture, worsening the already profound fatigue and sleep issues that characterize the syndrome. The risks are high, and the benefit is low to non-existent.
So if the pain is centralized, the medication needs to operate within the CNS. Which centrally acting drugs are the primary options?
The three main categories are medications that modulate the CNS in various ways. Tricyclic antidepressants, serotonin norepinephrine reuptake inhibitors, SNRIs like duloxetine, and the gabapentinoids like pregabalin and gabapentin. These drugs aim to normalize the balance of neurotransmitters.
But we have to acknowledge the caveat here. While these drugs are approved, their efficacy is often, well, it's disappointing.
It is, and this speaks to the complexity of the underlying mechanism. These medications only provide small improvements, often cited as a change of only 5 to 20 points on a 0 to 100 pain scale. That's a small clinical gain.
And they frequently cause adverse effects that specifically target the patient's existing symptoms, like worsening fatigue or cognitive impairment.
Exactly. The cost-benefit analysis for the patient is often highly unfavorable.
This limited efficacy leads to the contradictory guidelines the sources mention, highlighting the ongoing discrepancy in best practice globally.
Yes. For example, some regulatory bodies have approved pregabalin for use in fibromyalgia. Yet the NICE guidelines in the UK, when managing chronic primary pain, often recommend antidepressants as the only medication category to even consider.
So there's internal disagreement among experts.
There is, and it underscores how difficult it is to find a single effective pharmacological agent when you're treating a complex neuroplastic syndrome that lacks a clear biomarker. The mechanism is real, but the molecular target is still elusive.
Are there any promising novel approaches currently in the research pipeline?
There are a few. Low-dose naltrexone, which is an opioid antagonist, has shown some preliminary benefit, potentially by modulating microglial activation. Additionally, research continues into cannabis-based medicines and emerging neuromodulation techniques like transcranial magnetic stimulation, but these require much more rigorous study.
So if we synthesize everything we've covered today, the official introduction of nociplastic pain represents nothing less than a revolution in the understanding of widespread chronic illness.
It provides a scientifically robust, physiological framework for understanding these common, debilitating chronic pain syndromes. The central takeaway must be that these conditions are not phantom illnesses or purely psychological expressions. They're an amplification issue within the central nervous system.
A learned state of hypersensitivity.
Right. Which finally validates the symptoms that were previously dismissed as being in the patient's head.
And this classification allows clinicians to move from a frustrating search for tissue damage to a focused, mechanism-based treatment strategy. The sources confirm this framework is still evolving toward a future of precision medicine.
Absolutely. The next major leap will be in precision medicine. Researchers are intensely focused on moving beyond the descriptive phenotype to identify discrete pathophysiological pathways and, crucially, reliable, non-invasive biomarkers.
So you could tailor treatment specifically to the individual patient's type of sensitization.
Exactly. Whether it's a GABA deficiency, glial cell activation, or diminished descending inhibition, key research questions remain. Why are some NP presentations localized while others are diffuse? And how can we identify the specific preventable triggers that tip the system into this chronic state?
This entire deep dive has been rooted in the concept of neuroplasticity, the brain's ability to actively change its wiring, structure, and function in response to persistent signaling.
The nervous system is learning to experience pain at an amplified, systemic level. That's the key insight. The pain persists because the CNS has learned to be hypersensitive.
And that leads us to our final provocative thought for you, the listener, to carry with you after this deep dive.
We know that in chronic musculoskeletal pain, structural findings often show a very poor correlation with symptom intensity. Considering that nociplastic pain is fundamentally driven by neuroplasticity, the brain's ability to change its own structure and function, If the experience of persistent, debilitating pain is less about irreversible physical decay and more about a learned state of heightened CNS sensitivity, how does this fundamentally change your perspective on healing? And specifically, how does the responsibility for managing stress, prioritizing psychological well-being, and carefully pacing physical activity become an essential medical intervention in your own life?